All right, welcome to listeners from our institute, the Fitzhugh-Mullen Institute for Health Workforce Equity. We're reaching out from George Washington University School of Public Health as part of a series of discussions with experts on emergency health workforce policies to address the current COVID-19 crisis. The spotlight of today's webinar is on telehealth, and I am Guinevere Burke, a member of the Fitzhugh-Mullen Institute for Health Workforce Equity, practicing emergency physician and director for the Atlantic Fellows for Health Equity at GW, an international fellowship designed to provide advanced training for health equity leaders in diverse health professions fields. I'm joined by Sanjeev Arora and Bob Phillips, and I'd like to take a moment and ask you each to introduce yourselves. Sanjeev, can you start us off?
Yeah, my name is Sanjeev Arora, and I serve as the director of the ECHO Institute at the University of New Mexico. I'm the founder of ECHO 2 and a gastroenterologist by profession. Over.
Thank you. And Bob?
I'm Bob Phillips. I'm a family physician and executive director of the Center for Professionalism and Value in Healthcare in Washington, D.C., and current co-chair of the National Academy's consensus study on implementing high-quality primary care.
Excellent. Thank you, Dr. Arora. Thank you, Dr. Phillips, for joining us today. With the developing pandemic, we're seeing an increased focus on the health workforce, and this has been our long-standing focus at the Mullen Institute. So we're excited to really focus on this issue through the lens of telehealth, specifically focusing on its ability to protect and support our health workforce, how to maximize the current workforce and potentially even bring new workers into practice to meet the increasing demands, of course, for clinical care in the current climate. We're also going to address how to maintain ongoing essential healthcare services outside of the coronavirus, because other conditions like chronic disease management, diabetes, hypertension, mental health, they continue to be with us. They continue to have strong needs in the community. So let's go ahead and get started. Dr. Arora, you have pioneered a model to really support primary care providers in managing complex cases. And now that model, as I understand it, is being adapted to COVID. Can you just give us a brief overview of the Project ECHO model and how you're adapting it in the current environment?
Yeah, well, thank you for the opportunity, and nice to meet you all. I think that ECHO started actually, in 2001, I saw a patient, she was a 43-year-old woman, and she came to see me, and we found, she said, I have hepatitis C, and I want treatment, and she had 2 children sitting in the room, 14-year-old boy, a 9-year-old girl, and asked me, and so I asked her, how long have you had it? And she said, I've had hepatitis C for 8 years. So I said, why didn't you come earlier? And she told me she lived, 5 hours drive away, and there was no way that she could just come 12 times while getting interferon and ribavirin treatment, and there were no specialists in her local area. And she had called my clinic. There was an 8-month wait to see me, and so I asked her, what made you come today? And she said, I'm having pain in my right upper abdomen. So I asked her to do some, requested her to get some tests done. She did an ultrasound, and she had a cancer in the liver about the size, of a tennis ball. And it was too late to treat her, and she passed away about 6 months later. I asked myself, what really happened here in the United States, where I have all the medicines to treat this patient, all the tests. And what happened was that the right knowledge didn't exist at the right place at the right time. And so she could not get the right care. And she wasn't able to get to the place where the right knowledge was. And so that's how the ECHO model was developed, because at that time we had 28,000 patients with hepatitis C, less than 1,500 had been treated. It was a chemotherapy-like regimen. And I said, I want to treat every one of them in their local communities. So the model is based on amplification. We use one-to-many video conferencing technology, like telehealth, and to leverage the expertise of specialists at the university, what we did is we created 21 new centers of excellence for treating hepatitis C in primary care settings in the United States, mostly federally qualified health centers and prisons. And what we did is we gave them our protocol, but not a single one of them was willing to treat hepatitis C with the protocol. So I asked myself, how did you become an expert in hepatitis C? You were not born a gastroenterologist. And the way I did it was did my fellowship, and I would see a patient present to my professor, and after 2 years, they started calling me a gastroenterologist. So I said I would use the same model to create new hepatitis C specialists in primary care settings. Just a few of them, 21 out of, let's say, a few thousand in New Mexico. And they would then be specialists in their community. We call this case-based learning with an iterative guided practice in which all teach, all learn. And then we would use a web-based database to monitor outcomes. On the next slide, I show you what a typical echo clinics looks like. This is the expert team, and all 21 join, present patients to each other in de-identified ways. We discuss them, and we do this week after week. And what we found was that literally in a year, all of them became specialists, and the wait in my clinic fell from 8 months to 2 weeks. And on the next slide, the primary difference between what this is, tele-echo clinic, which is also telehealth, and traditional telemedicine is here, our goal is capacity building in primary care. So in a large primary care practice, we might create one expert in diabetes, one in hepatitis C, one in substance use disorders. So we train teams in primary care who then help hundreds and thousands of patients. Whereas in traditional telemedicine, which as you know is so important right now, for COVID-19, a doctor can see a patient remotely. So we are capacity building, telemedicine is treating patients remotely, and both are very complementary. On the next slide, I wanted to just show you what the current status of the ECHO network is. We have a goal to help 1 billion people, and by 2025, in order to get there, we train other universities to do it. George Washington, for example, is one of them we've trained. We have 389 hubs in the world, which are universities. They connect with 20,595 organizations in 153 countries, and they run 100 different types of ECHO network, hepatitis C or diabetes or HIV, and you can see the exponential growth. And currently, what we are doing in COVID-19, Dr. Burke, is that in all of the history of ECHO, we have trained about 97,000 mentees, but in the last 2 weeks, we have now trained more than 100,000 additional physicians and nurses across the world in these 153 countries on COVID-19 best practices, which are of many different kinds. And if there was an interest, I could later on tell you what those are, but I'll stop here and give it back to you, Dr. Burke. Thank you.
Thank you. It's exciting to hear about the uptick in particular and how you've been able to scale. To be clear, it sounds like before the current COVID crisis, there were a number of specialists who were staffing the ECHO hub sites. Who's staffing in the current climate? Who's providing support to the expanded network?
So we have fundamentally two kinds of, two broad strategic directions in COVID-19. One is called what we call amplification of the public health response. What does that mean? That means social isolation. It means how to scale laboratory capacity, how to test remotely, how to, and so on and so forth, how to improve laboratory quality, how to reduce the amount of risk to a person who's taking the test. Because when you take the test, it can stimulate cough or a sneeze. And how do you wash, these personal protective equipment? Those are the kinds of things that are in the public health amplification. And we've done lots and lots of those all over the world. But the second one is amplification of the care response. And so for amplification of the care response, is something like, I will show you what we are doing in the care response and outpatient setting. So how to adapt and reinforce rigorous infection control practices, how to cope with these PPE shortages to minimize waste, how to extend the life, how to use ultraviolet rays to screen, how to screen and triage patients at clinic entrances, how to deploy telehealth services, how to send, when to send to the ER, when to determine care at home, how to manage people with serious chronic diseases, how to integrate with public health, how to deal when your providers call in sick, and so on and so, how homeless, sheltered, all of that is an example. You would need to share your slides again. So we do some of those. And then what we do, Dr. Burke, for inpatient settings are very different. So in the outpatient settings, there are infectious disease doctors and so on and so forth, and public health experts. But in the inpatient hospital trainings, we have pulmonologists and infectious disease doctors, because what they like to train on is how to create a COVID-19 floor, how to treat these patients. 10% of people are being hospitalized. Whom to send to ICU? 5% need ICU. In low-income countries, we are using how to share ventilators. How can one ventilator ventilate 3 patients? There's a lot of best, so it's all different best practices in different settings. And so we have these specialized networks. We have echoes for HIV patient COVID-19. We have echoes for, and so on and so forth. Disabilities, homeless populations, et cetera, et cetera.
That's very interesting. So you've described so far, a couple different approaches in 2 large buckets, public health as one, kind of clinical care direction in another. I'm curious to hear, is there a role for Project ECHO in lending emotional support to providers as they're struggling under the burden of the current crisis?
So currently we have 3 such networks, one run out of the National Association of Public Health Institutes. We call it Resiliency. And we have 2 other networks nationally. We are finding, Dr. Burke, you're very, very perceptive, that in our echoes, we are finding that there is a massive amount of anxiety in primary care doctors right now, massive stress. And we see that as a huge need. And in our echo sessions right now, we have 1,000 people joining simultaneously. When we do webinars, sometimes 1,500, 2,000 people join, because the need is enormous. And if you do have specialized expertise in this area, I would love to help you start an echo in that area also. That need is infinite, literally everywhere in the world.
Yeah, we're certainly seeing it in our emergency providers as well. In talking about the great need that exists, one of my last questions for you would be really about how people can join the current effort. So is this something that's open to people who aren't already involved in the ECHO network?
Yes, absolutely. It's open, and there's no question about it. But there are networks run in every state right now. So I would contact your university, wherever you are, and they're doing COVID-19 echoes right now. And if they also want to write to my team or where they live, etc., we might be able to connect them to someone. But I think we want to do that. Also, if they go onto our website, you'll be able to see all the different echoes are occurring in your region. And I'm going to just show them where to go if that's okay. It's got echo.unm.edu. This is our website. And if you look on the right-hand side, you'll see the countries. You can say, okay, what's going on? This is worldwide, right? You click on Canada, and you'll see there are 17 hubs, 4 countries participating, 207, so many learners, and 815 organizations are participating. And then, you'll be able to see, if you go into our website and see, for example, filter by hub. In your town, you might be able to see by focus area, by hub, you will be able to see University of Toronto there, and then call them. And so essentially there's resources on our website that will also help you. I'll stop sharing. Okay.
Excellent. Well, thank you for that. It's really helpful, and I'm sure many people will benefit from being able to access those types of resources. I do want to shift now to Dr. Phillips. Project ECHO is a fantastic example of a novel program that's rapidly coming to scale. Of course, we're also seeing a lot of efforts on the federal legislative front to try to address what's going on. I was listening to a speaker from the American Telemedicine Association recently who said we've seen kind of more movement in terms of federal health policy on telemedicine in the last 2 weeks than in the last 20 years. And I haven't been working in telemedicine for quite that long, but there certainly is a lot happening. So Dr. Phillips, can you let us know what are the new federal government regulations regarding telehealth? I guess specifically, let's start with Medicare.
So thanks, Winter. There's actually two important changes that have happened. One is on the Health Insurance Portability and Protection Act, and the other is on Medicare payment. So on the HIPAA side, and HIPAA is enforced by the Office of Civil Rights, they've said that they will not enforce, or they will use discretion in enforcing any penalties for noncompliance with the regulations under HIPAA, and will really take into account any good faith efforts to use telehealth in ways that may not be typically compliant with HIPAA. And they've actually been very specific about using certain, if you don't have telehealth embedded in HR, function of HR, and existing platform, webinar, and they're very excited about those and saying that you can. They encourage people to get a business associate agreement with some of those, but things are happening so fast. I myself have found that to be very hard. Back retroactive to March 6th will pay for telehealth visits. You have to have both video and audio components for this to apply. And they've actually come up with a new code that you have to apply to those visits to make it clear that they're telehealth. But they said that they will pay for all visits for all types and all purposes, not just COVID-19 in this window of the pandemic. As you said, things have changed very rapidly after years of trying to get expansion of telehealth, both protections under HIPAA and payment. It's going to be hard to put this genie back in the bottle. I think a lot of practices will want to continue using this, and a lot of patients, frankly, will want to continue using this.
Yeah, I agree with you. And I think that's hopeful for many of us who've been working on this for a long time. For instance, at GW, we've had a long effort to try to incorporate this into residency training, anticipating that telemedicine would be the future, and always kind of competing with traditional clinical demands and topics. But I agree. I think now that many people will have new encounters with telemedicine that are hopefully very positive, the progress will continue. What about at the state level? Any comments on how states are responding with new policy approaches?
There are, and you know, bridging between national and state, one of the other things that got relaxed about licensure laws is that you don't have to be in the state, the patient and the physician don't have to be in the same state for licensure rules. And that's come into play for me several times with patients who are off to example. States are quite variable. I think there's some general uniformity of coming into alignment with Medicare policy. Virginia, for example, where I practice, has actually gone one step further. They will pay under Medicaid for audio only telehealth. So telephonic consultations they will pay for as well. I'll get to my own experience in practicing this week, but that's extremely helpful. Commercial payers, frankly, I don't even know what our commercial payers are covering for telehealth, and I'm hoping our practice and practice coders know that. But that variability from Medicare to Medicaid to the commercial plans is right now a great source of confusion for a lot of practices.
Absolutely. So let's shift maybe to what you have been seeing or what other practices may be seeing in terms of kind of the decrease in traditional in-person office visits. And as you mentioned, kind of confusion about which payers are paying for what. Is this already having, or do you anticipate it will have, a significant financial impact on existing primary care practices?
I really do, and I think independent of telehealth, a lot of practices across the country, primary care practices, are seeing reductions in visit volumes of 50 to 70%. That's the range that the National Association of Community Health Centers has said that they're seeing in fairly qualified health centers. And we're hearing the same thing from the field from non-FQHC outpatient clinics. My own practice saw a 60% reduction in visits, and some of that's on purpose because we want to keep people who are sick or who are well away from the clinic, particularly people who are vulnerable, immunocompromised, or older. And so we've actively called them and asked them not to come in. And there are folks who are just afraid and are socially isolating or distancing and don't want to come to clinic. So that fall off in volume is affecting a lot of practices. Our shareholders in our practice actually voted themselves a 50% reduction in pay for the next 3 months in order not to staff. And we estimate for one third of family physician practices across the country are still independent. And if you just look at that third, they're probably facing $500 million in shortfall over the next 3 months. So we could see practices close. We could see practices put people on leave or furlough right as we hit peak in this country. So there's great concern that we may see a real problem with access. And then we're also concerned that after this is over, that we may see a lot of practices that are bankrupt as a result.
Yeah, that's scary to think about in the face of so much need. From your perspective, building off of that, what is really needed from a policy perspective that we haven't talked about so far to strengthen primary care with a specific focus on telehealth?
With a specific focus on telehealth?
Yes, because I'm sure there's many other policies that are needed.
Yes.
And we can go on and on.
Absolutely. I think with respect to telehealth, it would be helpful if there was some uniformity, if less variability across the different payers. It would actually be helpful if there were some enhanced payments. And part of that is because we're finding that a lot of our small and independent practices don't have a good telehealth solution, at least not a formal one that integrates with their electronic health record. A recent survey of some of those practices have said that upwards of 70% have not found a solution yet. The other reason for the policy becoming more uniform, I saw 12 patients on Wednesday. All of them were some form of telehealth. The majority of them were actually integrated telehealth because we were able to ramp up our telehealth platform over the last week. But I had 3 patients that couldn't navigate that, and we went to FaceTime. And I had 2 other patients who couldn't even do that, so we went telephone. I have no idea. Oh, actually, I know that Medicare won't technically pay for the telephone calls, although they will for the FaceTime. And I have no idea about the commercial payers. So there's a need for them to come together on what those policies look like. I would also say that the relief bill that just passed the Senate has about, I'm going to get the number a little bit wrong, it's close to $50 million in telehealth support. And so I'm hoping that will enable a lot of the smaller practices and rural practices to get some help with ramping up their telehealth capacity.
That's great. That's exactly where I was going to go next in terms of kind of providers who are facing limited resources or taking care of vulnerable populations, specifically FQHCs. Any comments there about how FQHCs have been approaching telemedicine, how they're being supported or not supported in the current policy climate?
Well, I have to draw on what I've heard from our friends at the National Association of Community Health Centers and the National Rural Health Association. Both of whom are saying the problem that we're experiencing outside of those entities, it's the same. Fortunately, those organizations are doing a lot to help point their members to solutions. The High-Tech Act, which helped community health centers not only bring in electronic health records more broadly, but help them establish some of the meaningful use functions much better than a lot of other practices, may also have enabled them to do more with telehealth, or at least be prepared for it more. So my hope is, and what I'm hearing is that they may be in a better shape in this regard, but affected by policies the same way.
All right, so with that, I'm just going to shift, and either or both of you can comment. The Mullen Institute does specifically focus on health workforce equity. So we talked then about FQHCs in particular, but other ways that you see a role for supporting our most vulnerable populations or safety net providers with your current knowledge of programs or policies. I've seen dialogue, for instance, about support of community health workers via telemedicine or other novel approaches. Any comments on how to support safety net populations and providers?
I can start with that. I think our mission at ECHO is to democratize best practices and implement them for underserved populations all over the world. So essentially, that's our predominant mission, is to reach those marginalized. Now, in the United States, they often get care at federally qualified health centers. That just happens to be because they're low income. There's racial minorities often attend there. And also, for this reason, we have focused a lot of our attention with ECHO around the United States on federally qualified health centers and people who take care of marginals, so clinics for homeless people, clinics and so on and so forth. But certainly private practices also join, but our active recruitment is for that. The second problem we see for these populations, Dr. Burke, is that these populations have very difficult time accessing specialty care, even in their universities. A lot of universities and specialists are not very keen to fill their panels with Medicaid patients. And so Medicaid patients often experience long waits. Also, there are a large number of states which haven't expanded Medicaid. And then what happens there, of course, is that these uninsured patients don't have access to specialty care at all, but they do have access to care in federally qualified health centers for primary care. So we move the specialty care to the primary care setting where there is actually reimbursement, et cetera, and support for that. So that's our strategy for that part. You're absolutely right on about this issue of community health workers. And for that reason, we have started community health workers in many, many countries and very large in the United States to enable them to become patient education and support workers for these particular individuals. So for example, we have community health worker diabetes experts, which we train, just like we train doctors and who patient, because they often don't have in these rural areas or in urban underserved clinics enough diabetes educators, for example, or addiction support workers and so on and so forth. And we also in the prison, which is another very marginalized population, we have very large community health worker programs. For example, we've trained 10,000 prisoners there on different aspects and things like that. So that's our approach with ECHO, to use our all teach, all learn model to scale up expert knowledge in these communities. The
only other thing I would bring up is about the power of data sympathy. And what I mean by that is if you look at CDC's Sentinel networks right now that they're activating, trying to watch the pandemic as it spreads across the country, almost all of their resources have been put into hospitals. And we've been in negotiations with them for the last week and turning our national primary care registry into an influenza-like illness Sentinel network because it's predominantly in small and rural areas in 47 states. We've also contacted OCHIN, which is the largest prepare network for community health centers. So it covers 23 states, almost all federally qualified health centers. Because we believe if we can help CDC by sharing data with them about what's happening in these rural and underserved areas in the pandemic, that it may help focus their attention and resources on these areas too. I think that there'll be a long tail to this epidemic and that it will be longer in these rural and underserved areas that are more isolated from large cities, and that there's a lot to learn from it. And there's also a lot through that data sympathy, there's a potential to bring attention and resources back to those same communities, whether it's protective equipment, whether it's serving hospitals there, whether it's getting telehealth into those small practices. But just being aware and having data from those places may help us shift the policy focus in the right way.
Thank you so much. Well, Dr. Arora, Dr. Phillips, I'm prepared to wrap up any closing comments on our current environment, other programs or policies that we haven't touched on so far.
I just want to thank you for this session and also congratulate Dr. Phillips for his really important work in this area, and really grateful to get a chance to meet you and see you also.
Well, and I'm grateful. I've always loved the intentionality of the University of New Mexico and Project ECHO specifically, and I appreciate your using it to help in the middle of this pandemic.
Thank you.
All right. Well, many thanks, Dr. Arora, Dr. Phillips. I'll leave our audience with a quote from our founder, Dr. Fitzhugh Mullen, that health workforce policy is increasingly a health equity battleground. I think we're certainly seeing that play out right now. Thank you so much for your time, and thank you for joining us.
Bye-bye.
Thank you, Guinevere.
Thank you. It was a pleasure. Great hearing about your work.